Me too, so I can share. Hello, everybody. Happy Friday. We are live today with Dr. Priya Mistry. Thank you so much for being here, the TMJ Doc.
Yes, thank you for having me.
So we're going to first start. I'm going to ask Dr. Priya to introduce herself to you guys if you guys don't know her yet. Go ahead.
All right. So everyone, I'm Dr. Priya Mistry. I am a general dentist. I have a practice in Portland, Oregon, where we are dedicated and limited to taking care of patients with TMJ disorders. Are you guys hearing an echo? Because I'm hearing an echo.
Yeah. Let me turn it down so it gets better. How's that?
I think that's better. Much better. Thank you.
Yeah.
I just didn't want to hear my own voice echo this whole time. So I met my mentor in 2018. So I was practicing general dentistry from 2007 to 2018. And then I met my mentor, who has been doing TMJ work since 1980, before I was born. And he was really looking, he's really amazing. And so he was truly looking for somebody to come in, and he wanted to share his knowledge, have his legacy live on, and he wanted to keep his practice going, essentially. And of course, and so we met and we just meshed really well. And so I've been learning with him and working with him since 2018. I just bought the practice in March. So it's my practice now, but
Congratulations.
Thank you. But he's still very much a part of it. So he's there at least 2 to 3 days a week. We're open 4 days a week. So he's still very active in it. I would say I'm still very much learning from him, because there's so much to learn in this. And so that's a little bit about me. And I just really love what I do. I'm very passionate about it. So thank you for having me today.
Of course. Thank you. Of course. How did you first get into it? I saw on your bio that whenever you were a kid, you had an accident. Can you tell us about that a little bit?
Yes. Yeah. So that kind of encouraged me to pursue dentistry in general. So I had an accident where I was actually hit by a car, and I went flying, and my only injury was that my front 2 teeth were cracked in half.
Thank God.
Thank God, right? I must have a head that's harder than a brick or something. But so I was 9 years old at that time, and I was devastated because these were my permanent teeth, and I just thought I'd have to walk around with teeth that looked like that for forever. And so essentially I ended up seeing our dentist, and he fixed it right up within an appointment. I was lucky. I didn't need root canals, and he just did some fillings, and I was so amazed by his work that I was kind of, after that, I was very much interested in dentistry, and it just sort of evolved from there. So that's what got me into my field.
That is amazing. Well, our topic today, guys, is TMJ. So temporomandibular joint disorders. You know, a lot of people will come in and they say, I have TMJ. We all have TMJ, one here. But we usually call it TMD for temporomandibular joint disorders. And you can explain a little bit if there's a difference or where the issue is. So we call it a different name. So Airway and TMJ, how those are related. Come over here, honey. I am live. She came to bring my earphones. Thank you. You don't have to show up if you want to.
May I have my gummy?
Thank you. Yes, you can have one. My goodness. All right. So, so many people suffer from TMJ issues today. What are some of the most common complaints patients bring to you?
Yeah, so actually the number one reason people walk through my door it's headaches. So headaches are often, people are kind of chasing their headaches, or they see a neurologist, they're on really strong pain medications. They don't really find a rhyme or reason or pattern as to what's causing them, what can help them. And so a lot of the headaches, I would say, that we see are originating with jaw issues. And so headaches are the number one reason people walk through our door, closely followed by like clicks or pops, like noises in the joints. And sometimes those noises can be associated with episodes of the jaw actually locking or catching. So I would say headaches and those joint noises are like the number one and two reasons people come see us.
Wow. And the treatment options, at a regular dentist are kind of limited. What are these doctors missing? Because we don't really know. I don't know. I'm not a dentist. What you learn in dental school related to TMJ, because there's not a real specialty, correct?
Right. And that's the tricky thing, is that I would say us dentists are missing a lot. and that's because in dental school, most dental schools and most medical schools, TMJ, it's not taught. It's not taught what it is or how to treat it, how to recognize it, really anything. And so it's one of those things where it's just a body part that's often overlooked. And so I'm not trying to make excuses for us dentists, but we're really not taught much about it besides the basic anatomy of it. So it can be really hard to figure out what's going on with the patient. So I have several patients now, hindsight is always 2020. And I'm realizing that in my 11 years of doing only general dentistry, there were 4 or 5 patients a year that would come in and I couldn't figure out what was going on with them. Where if they came into my TMJ practice now, I'll know right away because of my training with my mentor. And that's the tricky thing, is that most people that are practicing exclusively TMJ right now, like me, they've been trained by a mentor. They've been fortunate enough to have met a mentor that's been doing this for 30 years, for 40 years. Yeah, so I'm just really lucky. And there's no standardized way to treat this. There's no standard course that you have to take. I think recently it's been recognized as a specialty with the AACP, but I think even they have a different way of treating than like what I do at my practice. So that's the tricky part. And TMJD can also often be a whole body issue. So if you're going to your dentist, they're focusing on your teeth. They're focusing right here when it can be stemming from your neck. So it's hard. It's, I'm trying to, with my YouTube channel, I'm trying to bring awareness to both patients and practitioners. And there's actually a video that I did. I believe it's called Why TMJ can be difficult to diagnose and treat. So check that video out because I really go deep into it. Yeah.
We'll post it on Airway Circle so everybody can see it. Yes. And if you guys are not following her on YouTube, please do. Her videos are amazing. She gives some amazing tips over there and just knowledge about TMJ disorders that, it is such a complicated and complex.
So complex.
There's so much that goes into it. It's just not just the joint. Like we always say it's all connected.
All connected.
So usually the dental office right now, they just give every person that comes through the door, they're given the same appliance.
Yeah. So they
what do you think about that? Is there a better way of doing this?
Again, that's what we were taught in dental school. So, I mean, I feel like as dentists, we think we're following protocol. But the problem with giving everybody the same thing is that for some people, it might work. And then the dentist just got lucky because there's no rhyme or reason as to why we're giving every single person the same thing. Like if somebody comes in with their jaw locked, if another person comes in with headaches, if another person comes in with only jaw pain, why would you give them all the exact same thing? Right? It doesn't make sense, but that's what we were taught to do. So if you're lucky and it works out for the patient and they feel better, great. You're going to look like a hero. And of course, we're all trying to do good. But
exactly, of course.
Yeah. But I've seen many instances where that same appliance is given to someone and all they had was a little bit of clicking or popping, and now suddenly their jaw is locked after wearing that appliance.
Wow.
And now they can't open. And they're thinking, what happened here? So, and I've done some courses, I've done some webinars with the Academy of General Dentistry talking about how dentists can change their protocol just a little bit. It's one little tweak and communicating with your lab, and you can do so many patients good. And I'll send you the link for that too.
Awesome.
If there are dentists watching this that want to check that out, I think you can buy it online for like $50 or maybe even less if you're a member. But I feel like it's really valuable to incorporate those techniques into practice.
So is that training that you do?
Yeah, it's a course that I taught with the AGD. Yeah.
That's what I thought. Okay, so you offer, because that was going to be one of my questions. Do you offer training for people to find this information out there? Chris just posted something. I'm not sure if that's one. I think that might be your video. Thank you, Chris.
Thank you.
Awesome. Yes, it's so important for other providers to know that this information is available out there. You had your own mentor. Now you are going to be, so many other dentist mentors. So that is amazing.
Yes.
We need to make sure that the word gets out there. So we will for sure share that. So in clicking, popping, limited opening, is any of that normal at any time?
No. So ideally, we don't want any joint noises. We don't want any clicking. We don't want any popping. We don't want limited range of motion. And so there are several people who can go through their entire lives with every time they open, this side clicks, and it can stay like that forever. And then ultimately, if it doesn't progress, if it's not painful, if it's not limiting range of motion, fine. People can leave it alone if they choose to. Having said that, in a number of people that will progress, and that will turn into more frequent and more painful clicking. And then that could turn into the jaw actually locking. So it's kind of tricky because in dental school, most of us were taught that if it clicks, if it pops, and if it doesn't hurt, leave it alone.
Mm-hmm.
And I have a hard time agreeing with that because I see on a daily basis where it can lead, right? So I see the most extreme cases. So it's hard for me to agree with that. So ideally, no, we don't want noises in the joints. We don't want limited range of motion.
That's good to know. And when do these issues start? For example, clenching and grinding in children, or a mandible either too forward or the opposite, too far back.
Mm-hmm.
Can those issues eventually cause TMJ disorder?
Yes. So the mandible too far back can happen in the womb. So it's just all development. And my lovely daughter is a prime example of that. So she's 4.5 now. She was actually breech until 38 weeks. And then we had her turned from the outside. But because she was breech, she was like this in my womb. So her mandible didn't come down and forward.
Wow.
So we can see clearly that her mandible is really far back. I'm talking like 10 to 12 millimeters far back. And so, wow. Of course, as a dentist, we have plans on which appliances will bring her forward and all of that. So the mandible being far back can start from the womb. The clicking, popping, joint noises, we don't usually hear that because the body can compensate even if the mandible is far back for a long time. So we don't usually hear of it becoming a problem until puberty hits. And then the clicking and popping can start because hormones really do play a big role in what's happening in this joint. And clenching and grinding can start early in children if they have airway issues. If they're having trouble breathing, a lot of these kids will snore, they will clench and grind their teeth, and they will mouth breathe instead of nasal breathing.
So how does all the airway, so how does mouth breathing affect our joint? Can it negatively affect our joint?
Yeah, so mouth breathing by itself, if you just take mouth breathing, it doesn't do too much to the joints. But if you take everything that comes with that, because typically with mouth breathing, there's issues with breathing in general. Nasal breathing is way superior to mouth breathing. So typically if there's some mouth breathing, some clenching, some grinding going on, there's an airway issue. If there's an airway issue, our body goes into fight or flight mode. We become stressed, and what happens is we'll start to clench and grind. That's what it's kind of ingrained in us humans that when things are stressing us out, we'll just sink our teeth into it, kind of like dogs go around biting, but we end up clenching our teeth, and then grinding the jaw forward actually opens up the airway. So the action of grinding is our body's intuitive way of saying, hey, I need more air. Let me open up the airway. Let me bring the jaw forward. So all that clenching, all that grinding, it adds up over time. And our bodies can only compensate for so long because the forces of clenching, the forces of grinding, they're 80 to 100 times stronger than chewing forces. They're enormous or more.
Wow.
So you add all that up and eventually these muscles are not happy. These joints are not happy. It's too much stress. It's too much strain. That's when the headaches start. That's when the neck pain, ear pain, jaw pain, clicking, popping, episodes of the jaw locking, all of that will start. But it usually has a long history behind it. The only times I've seen it have a quick onset and a quick recovery is like whiplash incidents, like somebody that never had jaw issues. They don't clench and grind. They're nasal breathers, all of that. And they had a car accident, a really bad car accident, and they suffer a whiplash. Mm-hmm. Then it can feed up and affect the jaw. Once we get all of that calmed down and the neck treated, it goes away pretty quickly. But for people who have an airway issue, it's usually a long-term thing. It takes a while for it to manifest.
Very interesting. So you just mentioned, the neck and all of that. Do you work with any other providers? Do you collaborate with body workers or anything like that?
Yeah. So we collaborate mainly with upper cervical chiropractors. So these upper cervical chiropractors have extra training, additional training where the adjustments that they do on the neck are not high velocity. There's no cracking. There's no cracking of the neck. It's very subtle, but it's very effective. And so these upper cervical vertebrae are very intimately related to the jaw joints. And we really recognize that. So a lot of our patients who are locked have rotations in their cervical vertebrae. And so if we can work closely with an upper cervical chiropractor, that can be helpful. We also work with TMJ physical therapists that can help our patients assume postures that put the muscles in a more relaxed position. So I would say those are the two body workers we work most closely with.
That is amazing. We need to find people around us. So if you know anybody over here who's a physical therapist or a chiropractor who works with TMJ, tell them to go over to airwaycircle.com and join our directory. We're always trying to find each other, and that's why we created this free directory. Patients contact us all the time asking, I am in Texas or I'm in Colorado and I need somebody, and I don't know who to go to. I mean, just me being in Savannah, it's storming really bad here.
Oh.
So hopefully the connection will stay. Yeah. But even me being here, I had no idea that there were people around me that actually are doing some airway stuff. So I recently got connected with somebody 2 hours south, with another person 1 hour south, and now another person 45 minutes north. So 3 different dentists and orthodontists who are looking at tonsils and adenoids in children early, that want to see kids for early intervention, going ahead and starting expansion early. But I was oblivious of it, and I was thinking, oh my goodness, I'm over here all by myself, and I can't get somebody to collaborate with. It's difficult building a team, but so that is why we're doing this directory, and all of these connections didn't happen until Airway Circle started.
That's so wonderful.
It has been pretty cool. So everybody, if you guys have not joined yet, just go over on airwaycircle.com, click on View Directory, and you can, I think it's called Ed Listing. You just click on there, and it kind of guides you through. You can put your bio, you can put your professional services training, or any of that information. Do you
have any more snacks?
No snacks. You can talk to me right now, child.
Have any more snacks?
No, thank you.
You're not lying to me about no snacks.
Baby. Okay, Daddy knows where the snacks are. Sorry, they already had dinner. But that is why, this community that we are building and bringing together has been so cool. Just yesterday, I was on Clubhouse Wednesday. At 5:55 p.m. She does a Clubhouse for us with different guest speakers that she brings. And she was like, Renata, I have somebody to introduce to you. And he was a doctor that's really, really close to me. And I was like, oh my gosh, I've been trying to get in touch with him. But I didn't know he was already doing all this stuff.
Oh, nice.
So it's been incredible. If you have not joined yet, please, airwaycircle.com, add directory. You can put as much information as you do. And the more you add, the more people can search, because they are searched by keyword. But anyways, I hope lots of people, we're able to help several patients by having that tool available for everyone. Enough about that. Now we have a question. Can we go to a question? Suzanne asked, first she said, thank you for this. Dr. Mistry is awesome. Can you explain how you treat? Do you rehab up the whole mouth with crowns, OMT?
No, we actually don't do rehab. So my practice is very, I guess, like holistically and body-centered, and a lot of manual therapy. We're very hands-on. So I did have to take courses to learn how to do some osteopathic techniques. And so the way that we treat is every single patient gets the full examination when they come in. So that includes checking the bite, because obviously the bite can play a role in all of this. That includes checking the airway. That includes talking about sleep studies, checking the postural dynamics. So we look at the postural chain, the jaw, the spine, the shoulders, hips, feet. We do a complete assessment, and then we give our recommendation. And so all of our treatment plans are some variety of making custom-made mouthpieces, orthotics. So we measure
Okay.
where the muscles are relaxed and where the joints are
Wow.
aligned. Yeah, and we build the orthotics to that position. And when we do that, good things tend to happen. But we follow that up with our own extraoral and intraoral massage and myofascial release, and osteopathic manual jaw manipulation. So the jaw
Wow.
manipulation is a vital part of this treatment for clicking and popping and locked jaws. We do some injections in the joint itself. We do one injection to help get it unlocked, and another one to help tighten up the ligaments in there. So we have so many different treatment modalities, and so we don't do any full mouth reconstruction. That's considered phase 2. Phase 1 with TMJ work is pretty much always stabilizing the joints, getting them back to health, and getting rid of the pain. Phase 2 can be moving the teeth to that position with orthodontia, or restoring them to that position with the full mouth reconstruction. But going in and doing full mouth reconstruction right off the bat is not a good idea, because we have to find out where the stable position for the jaw is for each patient. So essentially, we always do phase 1. And then a lot of our patients choose to wear our nighttime orthotic forever. They're not dependent on a daytime one. They choose to wear the nighttime one instead of do phase 2. Some of them want to do phase 2, and then we refer to specialists in the area that do that.
It almost seems like every patient should kind of go through this phase 1 so we can see where the muscles are, because as soon as you put a crown, or as soon as you do a filling, things kind of change. As much as dentists try to make everything, be as perfect as it was before, we all notice a little bit of a bite change. Can that cause TMJ issues to start happening?
Yeah, that's a good question. So typically, doing one crown or one filling typically wouldn't cause the TMJ issues to start. Having said that, it can be the straw that broke the camel's back. So I had a patient, for example, who had 2 really minor fillings done on her right side, just 2 minor normal fillings. And after those were done, it was like severe pain all on her right side. Actually, my YouTube channel has her testimonial, so you guys should check that out. But she felt like someone was hitting her in the head with a 2x4, like sharp pains. She was crying all the time. Her whole life changed because of those 2 fillings.
Wow.
And, the fillings were minor. They weren't even close to the nerve. Like, I looked at them and they were done well. So I just thought, what is happening here? So after talking to her and interviewing her and sitting down and doing the comprehensive workup and exam, we figured out that she had had 4 whiplash incidents in a short span of time. And her neck was done. And so that appointment, for whatever reason, staying open for those 2 minor fillings, that was the straw that broke the camel's back. And her bite was fine. We didn't even have to touch her bite to get her back to a better quality of life. But we had to do orthotics. We had to work with an upper cervical chiropractor. She says that she's still not at 100%, but she's at 95%. But she could barely function when I met her. And so, that's why I don't like to go in and do bite adjustments. I don't like to do crowns. I don't like to do fillings. And I'm not bashing anybody that does it that way. I'm just saying that those are very hard to reverse. Whereas an orthotic is not. You just take it out.
Exactly. I mean, what you know. We do the best we can with the information that you know. And if you do want to learn more, there's plenty of options out there for us to get better at what we do. We need to always keep looking, because things are changing and evolving.
Yes.
And unfortunately, it's the fewer professionals who are always looking to grow and to learn. But anyways, we have another question by Kim. Do you find there are different TMJ symptoms between clenching or grinding? Or do you find both clenching and grinding present with the same TMJ symptoms? I'm not sure if I understand that.
So clenching is defined as just rhythmic up and down, opening and closing and biting down rhythmically. Bruxing or grinding is actually more lateral motion. So, yeah, so it's more of this. That's how it's defined. And so, yeah, you got it, just like that. And that lateral motion is not good for these joints. They're not built to take that. I mean, clenching isn't great either, but the lateral movement is really one that these joints can't tolerate.
Does that cause more pain because of the pterygoid?
It could, but I've seen clenching cause an enormous amount of pain too, depending on the force, the frequency, and the duration with which you do it. So no, I wouldn't say I see different symptoms with clenching versus grinding, but I think grinding can be harder on the jaw joints because of that lateral movement. But that's just my opinion. But I don't see different symptoms.
Very cool. Let's see what else we have. Guys, send us more questions if you have it. Oh my gosh, Christina, this is an amazing question. How long is normal to have limited opening following MMA surgery?
Oh,
do you work with a lot of MMA?
No, I don't really do a lot of post-surgical stuff. So I'm sorry, I'm not the person to answer that.
I'm going to bring somebody who does MMA surgery and we can ask them. How about that? Because that is a great question.
It is a good question.
Yes, guys, post any comments or questions that you have over here so we can ask Dr. Priya Mistry. Let me see what else I have to tell you guys about what's going on really quickly. Next week on Tuesday, we have everything about nasal flow and resistance with Dr. Karen. On Thursday, we're going to be talking to Dr. Jean Sambataro, who wrote Stop the Snore. So we're so excited. If you guys don't have the Clubhouse app yet, find us on our Facebook group, Airway Circle, and we can get you an invite. Any more questions, everyone? Please post them over here. Dr. Priya, let me see what else I can ask you. The pterygoid. I know you have a video that you show people how to release the pterygoid. Would you tell us a little bit about that and why it becomes so painful?
Yes. So I call the lateral pterygoid the troublemaker, but I've heard it called the terrible, which I wish I had come up with that one because I think it's a better.
I love that.
Yeah, it's a good one. So this muscle is a muscle that it attaches to the little disc of cartilaginous tissue within the joint, the superior head. So it has a superior and an inferior head that actually attaches, the superior head attaches to the disc. And this muscle is only about the size of the end of my pinky. It's a little muscle, but it is fierce. And so when that muscle becomes dysfunctional due to chronic clenching, chronic grinding, or sometimes even the way the teeth fit together can make that muscle dysfunctional. And when I say dysfunctional, I mean this muscle gets trapped in a chronic pain and spasm cycle. This muscle is not metabolically well. This muscle is not getting the oxygen and the fresh blood flow that it needs, and it's just angry all the time. So imagine just doing bicep curls all day. How angry would your bicep be? So imagine it angry like that all the time. That's what dysfunctional muscles mean. That's what I mean when I'm saying that. So when this muscle becomes dysfunctional, it can refer pain into the ear. It can refer pain down the jaw. It can refer pain up the jaw. It can refer pain behind the eye. There are fibers that extend behind the eye. And it can refer pain into specific teeth. So much so that people come in holding, clutching their jaws saying, I need a root canal, I have an infection. And they don't. They said the dentist can't find anything. And it's this muscle. This muscle is fierce. And so releasing this muscle is so important. And again, I did a video on that, which Renata just referenced. And so because this muscle attaches to the disc too, if that muscle contracts too much or it's in that dysfunctional state, it can pull the disc out of alignment. Click, pop, click, pop. And if it pulls it completely out of alignment, that's when the jaw locks. That's a condition where you can barely open two finger widths, and it's incredibly painful. And so getting in there and releasing that muscle, like I show you in the video, I think I actually say pinky and go opposite side here. What it can do is I've seen that get people unlocked. I've done that and gotten people unlocked. It's not common because usually we have to do jaw manipulation also, but I've seen it. It can really ease a lot of pain. And so a lot of the comments I've gotten after posting that video are, oh my gosh, I feel so much better. It hurts when you do it. It hurts a lot when you do it because that muscle's angry. But it's like it hurts so good. It's like working out a knot.
Knot in a massage.
Yeah, in a muscle. Yeah. So I think, you know, that releasing that muscle can relieve a lot of tension.
We do see a lot of patients with facial pain. Are those usually accompanied by TMJ issues?
Yeah, I would say that we are able to decrease facial pain pretty drastically because that facial pain is really driven by those dysfunctional muscles. And when those muscles become dysfunctional, they become edematous, they become swollen. And when they're swollen and edematous like that, it may not necessarily show because we were talking about small muscles here. So people don't walk in looking swollen necessarily, but the swelling that's happening in those muscles, it can push on nerves. And a lot of this facial pain is I guess regulated by the trigeminal nerve. So if that trigeminal nerve is being compressed, whether by a nearby blood vessel, which is trigeminal neuralgia, or by muscles that are angry and inflamed, TMJ, TMD, it can lead to a lot of discomfort. It can lead to a lot of
pain. And these headaches that TMJ dysfunction can cause, are they in a specific area?
No, we see them everywhere.
No way.
No, we see tension headaches. We see headaches just right across the forehead, right at the top. We see occipital headaches. We see migraines that start behind the eye. So my mentor always says all headaches, every single type of headache is regulated by the trigeminal nerve. And if you can lower the threshold of excitation, if you can calm that nerve down, you can do really great things. And so I always leave that in my mind, like all headaches are mediated through the trigeminal nerve. So
that is so interesting.
Yeah,
such a great way to put it. We have another question by Christina. How would you address a hypermobile joint in a teen?
That's a tough one. Yeah, a lot of young people are hypermobile. So hypermobility can lead to a couple different things. It can lead to the jaw locking open, where they're just stuck open. I've only seen that once because usually people get stuck closed. Or it can lead to the ligaments loosening up, the disc getting out of alignment, and the jaw locking closed. So it depends on what's going on with that teenager. So if they're locking open, we can't really do much because what's happening is the patient is opening so much, they're going out of the boundary of the joint and then getting stuck there. So for people that have a history of locking open, when they come to see me, they're usually not locked. They can usually maneuver themselves closed. I've seen one, again, like I told you, and I was able to maneuver her closed in like 10 seconds. But that's easy to treat, but it's not comfortable for the patient. But what I tell these people that are lock open is every time you bite into a sandwich, every time you yawn, every time you go to a dentist appointment or you scream on a roller coaster, keep it at 85%. Don't go to your full 100 because you're going to go outside of the boundary of the joint and you're going to get stuck there. So I wish I had a better answer, but really it's just being hyper flexible and I can't fix that, you know? And then for people who get locked closed, that's where our orthotics and jaw manipulation come into play. So I hope I answered that question.
Yes. How are these orthotics different than the appliances that we get made at a regular dentist?
Yeah, so a regular dentist makes a night guard, is what they call it typically. And then we make an orthotic. So it's very different. So it's kind of like the best analogy we can come up with is if you go to the store and you just get reading glasses. That's like a night guard. And then if you go and get your eyesight checked and a prescription, and you get prescription glasses, that's like an orthotic. So again, we're measuring where the muscles are relaxed and the joints are aligned. And we're building that to that position. So it's holding your jaw in a very specific position in 3-dimensional space to treat the muscles and to treat the joints. Whereas a night guard is not treating the muscles and the joints. It's simply protecting the teeth from the forces of clenching and grinding.
Wow. Oh my goodness. Everybody should know more about TMJ. How many more patients could we help with this information? This is incredible. Somebody just asked, are there options for patients with condylar resorption other than joint replacement surgery? Can the right orthotic help slow the progression, particularly if it's caused by a systemic issue like RA?
You know, I haven't seen a lot of condylar resorption patients, to be quite honest. And one acquaintance of mine was having condylar resorption to the point where her bite was changing drastically month by month because things were just resorbing so much. And she did have to get total jaw replacement surgery.
Wow.
And so I with COVID and everything, I haven't been able to see her and I haven't followed up with her that much. But if things are not progressing to the point where, you know, your facial structure and your bite is changing all the time, I would think that orthotics would be helpful to keep the pain away and to slow the rate of progression. Because this condylar resorption, nobody fully knows what causes it, right? But resorption is something that can happen, one, for no reason, or as a response to too much force. So if somebody's joints are just always super compressed, like there's not a lot of space between the bony components of the joints, and there's so much friction and everything's rubbing against one another in the joint, then as a response to all of that force, it can start resorbing and trying to get away from that force.
Wow.
And so I would think that an orthotic, because it creates joint space, it has a vertical dimension to it, so it creates space in the joint as well when you wear it in your mouth. I would think that that would slow that down. And again, this is me theorizing because I haven't had a patient with severe condylar resorption. We see degeneration in the joints. We see the joints, the bone roughened and breaking down, but I haven't seen somebody whose bite is changing on a weekly or a monthly basis like that acquaintance of mine. So that's the best answer I can give.
That is perfect. Nicole asked, how often is poor tongue posture part of the problem with TMD?
Oh gosh, 98% of the time.
Wow.
Yeah, it is. There's a direct correlation. So I actually made a video called Tongue Tie, Airway, and TMJ Disorders that I wish I could just play for y'all right now.
We might be able to.
Yeah. So please, just check that video out. But essentially, the vast majority of my patients have low tongue posture. The vast majority of them have tongue ties or sleep disordered breathing, because truly it all goes hand in hand. And so I would say it plays a big role in it. And I have some patients who come in and their jaw is locked and they say, just get me unlocked. I need to get on with my life. Other people say, get me unlocked. And what the heck caused this? What can I do? So I've had 2 patients go through not only the full TMJ treatment, but then after that, they went to myofunctional therapy. They got their tongue ties released. They trained their tongues to be up against the roof of their mouths. And, you know, with such changes, we even had to change the prescription built into their orthotics afterwards.
Wow.
But there's one patient, I'll send you the info, Renata, where I took a CT scan before and after her myofunctional therapy and frenectomy. And you see the airway increase. It might be on my Instagram too. I think you'll see it.
Okay,
but
I'll look it up.
It's amazing. It's amazing. And she went from having she had mild sleep apnea. She was definitely diagnosed with mild sleep apnea. So she went from having some apneic episodes to none with our,
wow.
Yeah, it's amazing. I mean, it can be truly life-changing, and tongue posture is everything. It is the root of everything.
So if somebody has a very high vaulted palate, doesn't necessarily have a tie, but they can't keep the tongue up there just because it's so high, is there a fix for this person?
That's a question. Yeah. So that fix, you know, Dr. Zaghi would say yes at the Breathe Institute, right? And so the fix there would be to expand that palate. But that is a tall order, and it can take a lot of time, money, and pain to do that. But is there a fix? Yeah, there is. But
and you'll probably save that person a lot of headache down the road also, and possible health issues, you know, that would come with mouth breathing.
Yeah.
So you guys work directly with the orofacial myofunctional therapy with your patients?
Yeah. So
that's great.
I was trained in myofunctional therapy. Yeah. So I love it. I think it's amazing, but I actually have a tongue tie. So
High five, sister.
I know. So I actually don't feel that comfortable teaching it because I
Mhm.
can't do it right. I can't do it
Mhm.
correctly. So I need to get all that taken care of. But we actually use BreatheWorks, which is a wonderful group right by us. And I love them.
Oh,
So
perfect.
we kind of start them at our office and then we usually send them over to BreatheWorks to finish it up. And especially the post-op myofunctional therapy, I want BreatheWorks to do it because I want it to be the best myofunctional therapy they can get.
That is great. Great to hear. Somebody said, Suzanne said, I try to tell patients to yawn with tongue on the spot. Is that for lockjaw, maybe? She was making a comment from whatever we were saying earlier. Kim said, what do you suggest for patients who have deviation of the mandible on opening and closing? Great question.
Yeah. So for those patients too, we treat them the same way. We do our orthotics, our muscle release, and our jaw manipulation. And so for our patients that have clicking and popping, they're seeing us for 4 to 6 months because that's not an easy fix. It takes time for the disc to remodel and get back in alignment. And usually in those 4 to 6 months, we see that deviation go. But you need manual therapy. I'm a big proponent of getting in there and manipulating the jaw, releasing the muscles. Oftentimes, the lateral pterygoid being hot is preventing one side from translating, which is causing the deviation. So, again, hands-on therapy, and some of this hands-on therapy can be done at home by the patient on themselves. And so, my YouTube channel, I'm sorry I keep referencing it, but there's so much
No,
information.
please.
I'm not trying to like sell myself, but there's
you don't have to.
there's one playlist called TMJ exercises / muscle releases. And it literally shows my patients how to do those on themselves, whether it's releasing the masseter, the temporalis, the lateral pterygoid, the SCM. So I've seen those deviations go away. We don't release patients from treatment until the deviation is gone.
Let's share this video, and I'll post. I'll pick a couple of your videos and I'll post on our Facebook group
Thank you.
And guys, share the heck out of it because plenty of people need this. You know, a lot of people don't know. A lot of people don't know they have TMJ issues.
Yeah.
You know, it's TMJ. So this is wonderful. Somebody said, my sister went to a TMJ and got exactly a night guard. She said he did nothing different than a general dentist. Does the appliance look different than a night guard, the orthotic?
Yeah, I mean, the main way that it looks different is that we have bite indexes. So ours fit on the lower arch, and they have bite indexes all the way around them that guide the upper teeth where to rest, putting the jaw in a very specific position. So it's not going to look different, and that's the tricky part. So kind of just like eyeglasses. If you were wearing eyeglasses, Renata, and I was, they would look pretty similar. But it's all about the prescription that's built into them. So you can't look at it and be able to tell. And that's the tricky part. And people will send me pictures of their appliance and I can't tell them anything from a picture. But if I saw their bite and I saw them in person with the appliance in and where it was holding their jaw, I could tell them a little more, you know? So sorry, it's hard to tell with a picture.
Yeah, that's fine. How about tinnitus and vertigo?
Yeah.
Because tinnitus, nobody knows what to do with tinnitus.
And to be quite honest, I don't know what to do with tinnitus either. That we call tinnitus the joker in the deck because it's the causes of it are so multifactorial. And my mentor actually believes it's a neuroplastic change. He thinks there's a change in the brain that leads to tinnitus. And so it may come on with the onset of other TMJ, TMD symptoms. And we've treated patients that have tinnitus along with a list of other TMJ symptoms. And we always tell them these will resolve and we have no idea what this will do. And so for some people, it gets better. For other people, it stays the exact same. I've never seen it get worse, knock on wood. I'm going to knock on wood with our orthotics, but we never say we can get rid of it. So tinnitus is a tricky one. Vertigo, we can treat pretty well. It can take some sessions, but vertigo, so the temporal bones house all the structures for balance. That's where the inner ear bones are. And so, or the structures of the inner ear rather. And so when those temporal bones get out of sync with each other, because these cranial bones have motion to them, that's what we believe causes the vertigo. So again, this goes back to osteopathic work, getting in there, getting your hands on the cranium and and finding balance in the movement of those bones, that's when we see that vertigo go down. And our orthotics are a big component of that too. It's holding the jaw in a position that supports the rest of the cranium too.
Wow, that is such good information. Guys, I think this is it. This is Friday night. You guys have been wonderful. I've loved the questions. So thank y'all for participating,
Thank
for being
you.
so good. Dr. Priya Mistry, thank you so much for being here, for sharing so much with us all. I'm going to share this video everywhere that I can, so
Thank
more
you.
people can get to know about this and start asking, because I feel like if patients are powered with this knowledge,
Sure.
they are going to go to their dentist and they are going to start asking questions.
Yes.
And hopefully those professionals will then look for your course.
Yes, I hope so. I hope so. It's out there.
Oh, yeah, there is. Well, thank you so much. You have a wonderful night.
Thank you.
And
You too. Thank you for having me.
of course, we hope to see you in the Airway Circle again soon.
Thank you.
Thank you.
Bye.